Welcome everybody to today's webinar from the Implementation of Scalability SIG. Today we have two speakers and we'll be talking about the implementation and scalability of efficacious health promotion programs, so understanding impact beyond the research setting. So our actual SIG, so we've only just begun, this is our first activity. The members of the special interest group are just on the screen here. If you haven't already registered as a member of this SIG, we encourage you to go to the ISBNPA website. We plan to send you updates on different activities that we'll be running throughout the year, and hopefully we'll see you in 2017 in Victoria. So just a few logistics before we get going. The webinar is being recorded. It will be available after the session if you do need to leave partway through. And we encourage you to ask questions throughout. Now at the bottom of your screen, there's a Q&A button on the app. If you click that, type in the question and submit. We will collate those and then we'll have a question and answer session in the last 15 minutes of the webinar. If you do have a question for a specific speaker, please just make that noted in your question. Any issues, just send them through on a question and we can try and sort those out. So I'd like to just introduce our two speakers today. So we have Associate Professor Luke Wolfenden. Luke is from the School of Medicine, Public Health, University of Newcastle in Australia, and he's also got a joint appointment with the Hunters Medical Research Institute in Newcastle. Following Luke, we have Associate Professor Chris Lonsdale. Chris is at the Institute for Positive Psychology and Education at the Australian Catholic University in New South Wales, Australia also. So Luke's research, Luke's going to be talking about the implementation of nutrition policies and guidelines in childcare services. Luke's expertise, he aims to seek to reduce the burden of chronic disease in the community, firstly by trialling interventions to reduce modifiable chronic disease risks, and trialling dissemination and implementation strategies to increase the adoption of evidence-based chronic disease prevention practices in the community. Chris is going to present on his experiences of developing and testing the IPAN intervention. And this is a real-world trial that actually aims to enhance physical activity via online professional learning for primary school teachers. Now, Chris's expertise, he's actually an associate professor and theme leader for the sport, exercise, and health psychology theme at the Institute for Positive Psychology. His research centres on the application of motivational theory to the understanding of physical activity and sedentary behaviour. More recently, he's begun to investigate how evidence-based interventions can be disseminated at a population level using online technologies as a supporting role. So both of those speakers will talk in a second. But before we actually start the presentation, I just want to quickly clarify a few definitions, just so that we're all on the same page, so that as a viewer you actually understand the terms that we're using and have some consistency. So in terms of implementation science, we're talking about the scientific studies of methods to promote the uptake of evidence in practice, essentially. So this encompasses both strategies, so that could be methods or techniques, to improve uptake and the implementation and sustainability of programs in practice. When we're referring to implementation, this is more a specified set of activities. So implementation research, that seeks to understand and analyse the processes used to implement policies and interventions within a particular setting. Implementation research is vital to understand context, assessing performance, implementation, and facilitating health system strengthening. And it's particularly important when trying to support the scale-up of interventions and integrating them into health systems at a national level. When we refer to scalability, so this has been defined as the actual ability of a health intervention to show to be efficacious on a small scale, under controlled conditions, and then expanded. In the actual scale-up process, this refers to deliberate efforts to actually increase the impact of health service innovations. And this is ultimately so that they have a lasting benefit on a larger number of people. Now, in terms of the theories, models and frameworks, Chris and Luke are both going to talk individually about the different strategies and the processes that they've used for their intervention trials. However, in general, in implementation research, there are several theories, models and frameworks that are commonly used and are quite popular. The examples on the screen shown, Peer Nielsen, that's just a narrative review of different implementation theories, models and frameworks. The bottom right-hand corner, CIFA by Laura Damschroeder, that's a particularly well-used framework that incorporates multiple domains. There's about 5 domains that include characteristics of the innovation, the implementers, the organisational level, the setting, and the process of implementation, all the different factors that actually influence implementation in real-world settings. In the corner, we have the WHO guidance for scaling up health service innovations, and equally, these all map across different domains. But one thing that's quite apparent across theories and models and frameworks in implementation science is they do have overlapping constructs. However, they don't actually specify the mechanisms for change. They inform on potential influences, which can assist implementation strategies and practice. But they don't always elucidate the mechanisms of change, and that's where implementation strategies come into play, which the speakers will talk a little bit about today. However, as I said, there is substantial overlap. A lot of these theories and models are actually based in more of a health service context as opposed to in the community, such as in schools and within workplace organisations. But they do have concepts that can be applied, and there is emerging evidence that's actually starting to develop frameworks that are targeted at these settings. And just lastly, before the speakers begin, I just wanted to put up the picture from the WHO Guide to Implementation Research. And this is an implementation research cycle, and it characterises what's typically depicted in the models and frameworks. 4 major steps are included. The first one, working with stakeholders in order to define specific health needs and identify appropriate policy and intervention approaches that are necessary. Secondly, is then adaptation of this policy or intervention to the local context so it can be implemented and used. The third step refers to the actual implementation and evaluation of the policy or intervention that's put in place. And lastly, is assessing whether this adapted policy or intervention, if it can be widely implemented and scaled up. So in practice, these steps aren't necessarily linear. They will go back and forth, and steps may change, and the actual role of stakeholders is heavily influential of this process of implementation. However, ultimately, these 4 steps that are on this slide actually characterise the type of processes that are involved. So on that note, I'd like to just hand over to Luke now, who's going to talk to you about his experience with nutrition policies and guidelines and implementing them in the childcare setting.
Okay, thanks, Harriet, and I apologise if I've got the brief slightly wrong. I'm happy to take questions specifically on how we've scaled interventions around guideline implementation childcare services. What I'll present, or what I've prepared today at least, is a broader outline or description of implementation research and how it can be applied to improve community nutrition and physical activity. And I think it actually leads well into Chris's very practical example of how he's approaching it in schools. But of course, happy to take questions on childcare specifically. Before I start, I just want to acknowledge the traditional owners of the land we're meeting on today and pay my respects to elders past and present. As Harriet mentioned in the introduction, so I'm an academic at the University of Newcastle. Perhaps importantly for this presentation, I'm also a health service manager within a population health unit. And so one of my roles is within the population health unit is the delivery of health promotion programs to the community. And I guess I'm drawing on that perspective a lot in the presentation today. So just to set the scene, I wanted to present the National Institute of Health's Process Model regarding how research is translated into practice. It basically describes 5 translation stages. So in translation stage 0 and 1, basic science and research, which really describes the etiology of health conditions and disease, is undertaken, and that research informs then the interventions and other tests of the impact of therapeutic interventions in translation stage 2. In translation stage 3, implementation and dissemination research is conducted, whereby we're primarily interested in moving or strategies to get evidence-based policies or practices or programs to the community. And stage 4 then evaluates population-level outcomes of efforts to implement evidence-based practice. So the work that I'll be speaking about today is really the interaction between translation stage 2 and translation stage 3, which is where scalability comes into it. So just by way of background, I think we're all here listening to the SIG because we acknowledge that there is an enormous gap between what research evidence says is effective in improving health behaviours and what actually occurs in policy or practice. And that's the case in public health as it is in clinical medicine. We know that internationally, childcare services fail to comply with dietary guidelines, and that's despite adherence to dietary guidelines being a requirement of childcare service regulations and their licensing and accreditation requirements. Some work we've done in schools in Australia suggests that in most jurisdictions only about 20 to 30% of schools adhere to mandatory canteen policies regarding the availability of unhealthy foods to children at school. That could be sold through the school canteen. And in health services, some research we've conducted suggests that between a third and just over 2/3 of allied health conditions routinely assess and provide intervention around lifestyle risk factors, including physical inactivity and diet. And that's despite best practice guidelines suggesting that they should do that routinely. And these childcare services, schools and health services are key settings in the community that it's recommended that we implement evidence-based policy or practice if we're to reduce the risk of chronic disease and chronic disease-related burden on the community. And the failure to implement evidence-based interventions means that there is considerable research waste. So all this research that we're doing to develop effective policies or practices can't actually, doesn't translate into any community benefit, which is actually the purpose of health and medical research, unless it's actually implemented. And there's probably the most cited statistic in implementation science is that it takes about 17 years for only 14% of research to influence policy or practice. And for health promotion research specifically, there was a nice little study done a couple of years ago looking at research funded by the National Health and Medical Research Council. And this is the best research that's been conducted in Australia, and it found that of that research, only 16% was having an impact on policy or practice. So, this is leading to considerable research waste and considerable translation delay. So why is there a gap between evidence and practice? So there are a variety of reasons, and I'm not going to go into a lot of them today. Often I guess the blame for a failure to implement evidence-based practice is laid at the feet of health policymakers or practitioners. For example, that their academic or scientific literacy isn't sufficient to be able to identify effective programs and actually use that evidence to form policy. And while some of those criticisms are of course well justified, in the presentation today, I guess I'm wanting to focus more on us as researchers and as an academic community. What can we do to improve research translation? And what I want to focus on is what I think is a primary impediment of research translation is this lack of alignment between the research that we're conducting and what the actual needs of end users are. And what I'll talk about today is, I guess, our failure, but also provide some guidance in the last couple of slides to provide researchers with the information that they need. And what end users or policymakers and practitioners need primarily is that they're solution focused, so they're primarily interested in interventions. They want to know what interventions will be effective if it's implemented in their local community context. So they don't really care so much about what interventions work overall, but if I was to implement a specific intervention in my specific context, is it going to benefit my community? Because it's my community that's paying for the implementation of this intervention. They want to know how can effective policies, practices or programs be implemented at scale. So once I've selected an intervention, how do I actually get that into practice? What's the rollout strategy that I should undertake? And finally, they are interested in knowing what are the costs or cost effectiveness of interventions and implementation strategies, and will there be any adverse effects if I undertake this intervention on my community? So if we just start with the first need of policymakers regarding what interventions are effective. So despite policymakers and practitioners being primarily interested in intervention research or research which is focused on finding solutions to particular health problems, bibliographic research such as this study we conducted a year or so ago now suggests that most research that's being produced is non-interventional. So randomised controlled trials or non-randomised controlled trials of interventions represent about 10% of public health research output, and the predominance of research activity in the field of public health is focused on cross-sectional studies and cohort studies. Over almost 3/4 of all research output is basically descriptive research. So the research that we're publishing is not really well aligned to the information needs of end users. And the interventions that are in the published literature often test the effectiveness of interventions under efficacy or highly controlled research conditions, and that provides, often that's far removed from the the real local operational context in which health services and other policymakers and practitioners exist. And we've actually reanalyzed interventions around child obesity and physical activity to have a look to see how effective are interventions that have been actually trialled in more real-world environments. And so we took first the Cochrane review of obesity prevention interventions for children. We dichotomized those trials based on whether they were conducted in real-world environments or highly controlled environments using the PRACES 2 tool, which is a validated instrument to do so. And what we found was that most trials that have been conducted are conducted under highly controlled research conditions, and they're effective. But when we examine the subgroup that were trialled under more real-world environments, the effect size is substantially reduced, and statistically speaking, these interventions are no longer effective. So we really have to ask ourselves how effective in the real world are these interventions that we're designing and trialling. So we first did it for child obesity prevention interventions. Megan Finch then recently published a review where we undertook the same subgroup analysis for centre-based interventions targeting physical activity. And again, we found that interventions that are trialled under highly controlled research conditions are effective in increasing child physical activity, but those trialled under more real-world environments are not. And so if policymakers or practitioners are looking for interventions that will be effective, in real-world contexts and for their local community, at least for child obesity prevention interventions and physical activity interventions conducted in childcare centres, we actually don't have a lot that we could say, yes, well, this is likely to work in your community. Some other limitations of the intervention research that's being conducted at the moment is that most are testing unsuitable interventions. So interventions that are being trialled often require external resources, skills, expertise, or infrastructure that isn't available in the community. They're often delivered by external experts, and local government officials and within local settings such as schools or childcare services don't have those resources available to us. And one of the reasons why we might be testing interventions that might have limited suitability for scale up is that there's little evidence of co-production. So if you look at the acknowledgements or the bylines of authors included in these published papers, there's very little acknowledgement or very little evidence that these interventions have been developed in close consultation with the setting or with the end users, such as policymakers who will be responsible for funding these and delivering these across communities at scale. Some other limitations is that the use of self-selected samples is rife. So most intervention trials might advertise for services or individuals that are interested in participating in a trial. So these self-selected samples are often highly motivated to undertake behavioural or organisational changes. We suspect that this is likely to inflate effects. So the effect sizes amongst this population are likely to be greater than those who might be less motivated or less ready to change. Trials that are undertaken using self-selected samples provide little evidence to assess its potential population reach. So even if we know or discover that this intervention works, now what's the likely uptake going to be at the population level? And unless there's some probability sampling into trials, and it's very difficult to understand or get a sense of what the likely reach or uptake of these interventions are going to be if they're scaled. And there's a potential that scaling interventions that have been trialled using self-selected samples might exacerbate existing inequalities, particularly if individuals or institutions such as childcare services that are more socioeconomically advantaged enter into these intervention trials or take up these interventions, and those that are less advantaged don't. And finally, the current intervention manuscripts provide limited description of context. That includes in terms of the population characteristics that the trial was undertaken in, but also other things that were ongoing in the environment that might give a policymaker some reassurance that this intervention was conducted in a context that's similar to the context that I'm operating in. And it's actually no surprise that many of the policies or programs that are adopted by governments are usually interventions that have been trialled in the same jurisdiction. So, policymakers are often very parochial. They want to know that before they invest significantly in the scale up of an intervention, that is being found to be effective, in their community. And so there's a strong bias to, adopting local rather than international interventions. Okay, so how can effective policy or programs be implemented at scale? Again, this is really a nascent state of research, particularly in community nutrition and physical activity. One of the reasons being that there's very limited research investment in implementation dissemination research. So in the US, for every dollar spent on developing therapeutic interventions, only a penny is actually spent on making sure patients actually receive them. And similarly in Australia, we have a separate bucket of money which is for research translation and getting evidence into practice. That's called the Partnership Grant Scheme. $20 million was allocated or awarded in the 2016 funding round for partnership grants, and that represents a fraction of the funds that's allocated for our project grant scheme. And the project grant scheme is really aimed at scientific discovery, and so that represents about 4% of NIH funding on projects. So there's a heavy skew of research investment, infrastructure and spending towards developing effective treatments or interventions, and not a lot of energy investment into actually getting those into policy or practice. And that's no doubt reflected in research activity that's undertaken by us as researchers. Andrew Malat did a lovely little bibliographic study where he categorised physical activity interventions as efficacy trials, as trials that were focused on replication, or those that were dissemination studies. And he reported that in 2009, only about 3% of all trials, all physical activity trials in that year that were published were focused on implementation or dissemination. And a colleague of mine, Serene Jung, also ordered reviews that were published in the Cochrane Library, and she found that only 2% looked at the impact of strategies to support implementation, dissemination, and 98% were focused on reviews that were assessing the impacts of health innovations or health interventions. And the Cochrane Library, actually has a review group called EPOC, which is dedicated to implementation and dissemination research. And so, 2% of Cochrane reviews being implementation or dissemination focused is likely to be higher than the actual prevalence amongst reviews generally in the literature, which is a concern. In terms of community-based healthy eating and physical activity interventions specifically, of implementation strategies specifically, the Agency for Healthcare Research and Quality did a systematic search up until 2008. It was published in 2010. It looked for any trial, controlled, using a controlled design or otherwise, that described the impact of implementation strategies of getting cancer prevention programs in practice. So this included, those strategies that interventions or policies that targeted, tobacco use, not just those targeting healthy eating or physical activity. And from memory, included about 20 trials. Many of those were just pre-post studies that were uncontrolled, and it identified that there was a gaping hole in the literature for policymakers and practitioners. There was an accumulating body of evidence about how to prevent cancer in the community, almost nothing to guide policy or practice regarding, well, now we've got these interventions, how do we actually get them in the community? We're currently undertaking a series of Cochrane reviews across multiple community settings, including childcare services, workplaces and schools. And we're looking at the effectiveness of strategies to implement evidence-based healthy eating, physical activity, obesity prevention, tobacco or alcohol programs. And similar to the findings of the Agency for Healthcare Research and Quality review, we're finding very few trials. I think there was 11 trials included in our childcare review. It looks to there'll be about 20 trials in schools and about a dozen in workplaces. There's considerable heterogeneity. Few trials test the same implementation strategy. There's heterogeneity amongst measures, so it's difficult for us to pool data across studies to make meaningful statements about the effectiveness of individual implementation strategies. Few studies have tested attempts to implement evidence-based interventions at scale, and we defined at scale as made it as greater than 50 organisational units, so more than 50 schools or 50 childcare centres or 50 workplaces. It looks like there might only be half a dozen of those. And overall, the quality of evidence is using grade assessments was judged to be very low, and that will be the case for all the reviews. And what we're noticing is that there's 4 trials that do report the use of theory or theoretical frameworks in the development of their implementation strategies. Many have applied, theories incorrectly. Few actually adopt or make use of existing implementation frameworks that have been designed to guide this kind of work. So there really is an urgent need to build this evidence base so that we can provide some meaningful guidance to policymakers and practitioners to get evidence into practice. So I just want to talk in a little bit more detail about the scale up of the physical activity, a school-based physical activity program called SCORES. So SCORES was a school-based physical activity program that was assessed using a randomised controlled trial in the Hunter region, which is where we're from and which is where our population health unit is responsible for providing services to community organisations like schools. It improved NVPA by 12 minutes, which was a remarkable achievement. So we sought to see whether we could take this effective program and support its adoption by schools in our region. And so we sat down with David Lubens and Kristen Cohen and other members of the team to talk to them about the program and what its intervention strategies included, and whether it was suitable off the shelf to support implementation by schools, or whether it required some adaptations. And we made a number of adaptations to the intervention to make it more suitable for scale. And by suitable for scale, I mean suitable for us as a population health unit to provide to us, or to support its implementation within our local schools. And the adaptations, we retained all intervention elements with the exception of community links. So in the original schools program, there were external organisations were invited to come into the school, like our local professional soccer team or football team would come in and run clinics at the school. We dropped that component because it wasn't something that we could offer to all of our schools, and advice from the original trial developers was that they didn't think that was, you know, a core intervention component that was driving the effects that they observed. We also reduced the, I guess, intensity of other implementation support strategies. So, for example, rather than providing a day and a half of support to teachers to improve the teaching of PE, we provided training that lasted about 90 minutes and tried to supplement that with, you know, phone calls and some, you know, additional videos to support their professional development. And there were a couple of other modifications that I'm happy to elaborate on question time. So we then did a cluster RCT of this program. We randomly selected schools from our region to receive support to implement scores. We did it with 47 schools, and we did find that we significantly improved implementation over a number of those intervention components, but we didn't improve overall NVPA. So our effect was about 1.8 minutes. That was non-significant. And that was an interesting learning experience for us. You know, there are a variety of reasons that we didn't approximate the effect found in the original trial. And again, I can elaborate on them, but I think probably what was driving the you know, the finding that we found in terms of its scale up and its impact on NVPA was the adaptations that we made to the intervention. And I think, you know, really highlight the need for careful consideration of adaptation and how that's undertaken before interventions are scaled, but probably just importantly is making sure that interventions that we test are as suitable as possible to take the scale, and that we test them under environments that would approximate their impact if they're implemented in the real world. Okay, finally, I'll talk briefly about what information is currently available around cost effectiveness and adverse effects for healthy eating and physical activity interventions. And similarly, there's not a lot of evidence. So James Kite from Sydney University did a review of systematic reviews of child obesity interventions a couple of years ago, and found that about half of published systematic reviews were funded by organisations that were responsible for, you know, implementing interventions in the community, so mainly governments. And despite the fact that these are commissioned systematic reviews, only, you know, less than a third actually discussed the policy implications of what they found. And again, few reported other information that policymakers and practitioners are interested in, including costs. Earlier than James' review, we did something very similar. Again, we reviewed systematic reviews of child obesity prevention interventions. And at the time, we found 44 eligible reviews and only about between 4 and 15% of reviews reported costs or adverse event outcomes. And probably one of the reasons that there are so few systematic reviews reporting this is that there are so few primary trials that actually report adverse events or cost information. And this is despite not only policymakers wanting it, but adverse events, for example, are commonly raised by research that we undertake when we're talking to policymakers. Some work we've done in canteens. One of the primary barriers to implementing canteen guidelines is the negative or perceived negative impact that might have on canteen sales, and schools are dependent on canteen sales to reinvest into the school. For example, to help fund disadvantaged children to attend school excursions. When we attempt to implement other programs like physical activity initiatives, parents and school teachers are often concerned about what other programs that might displace in the child's curricula, in the school curricula, and whether that will have any other detrimental impacts on student learning. So, while we're all, in this field to make a difference and improve, the health of children, and we have to be mindful that, we need, policymakers need to balance, potential benefits with potential harms, and they are acutely aware of constituents and political considerations, and these issues need to be covered off in the research that we conduct to make it easier for them to pick up interventions and to actually implement them in practice. So just a couple of slides on where to from here. So we need greater production of evidence that is aligned to the needs of end users, and this is fundamentally going to take, significant shifts in academic incentives for work and rewards. So this, I think, is occurring with the establishment of schemes or buckets of money that are specifically allocated to translational research. And there's also a move, particularly in the UK, but will certainly be here in Australia soon, where research impact is considered an important academic outcome, and academics are now needing to record instances of research translation or research impact. And once these incentives or drivers change, I'm expecting that research output and activity will also change. It also requires different models or methods of academic practice. So we need to, as academics, start with end use in mind. How is the research that I'm going to conduct going to improve health in the community? Is it aligned to the needs of end users? And to do that, we as academics need to engage with end users and start to invest in co-production so that research that we conducted is suitable for use. Another recommendation we've made in the past is the greater use of hybrid design. So hybrid designs is a typology and implementation science which suggests that intervention trials should include, all intervention trials should include some information about to support implementation or scale up. This could include simply just measuring the acceptability of the intervention to its users, all the way to actually testing the impact of specific implementation strategies. And if we see all implementation trials as a potential vehicle to add to the collective evidence base around implementation, then I think we could quite quickly build the evidence base and improve the impact of our current efforts to implement things at scale. We need to emphasise testing interventions under real-world conditions and place a greater priority on external validity in our research designs. While we're waiting for evidence to accumulate regarding the effectiveness of strategies to implement things at scale in community settings, it's probably good to look at parallel evidence. And so we should look at clinical settings where there's actually quite a large volume of research around what works in changing clinicians' behaviour. So we could use those principles to guide the development of our strategies to change the behaviour, for example, of teachers or childcare workers. We need to make greater use of existing implementation frameworks and procedures to guide our selection of implementation strategies, make sure that they're closely aligned with current barriers to implementation. And again, that will involve co-production. And I don't have any evidence to support this, but my experience is that the best outcomes that we've had in our large-scale implementation efforts is when we've invested considerably in formative evaluation, and we've got a very intimate knowledge of local context. And so what that has literally meant is getting away from behind our computer and what the evidence says are barriers and facilitators to certain policies or practices, and we actually go and spend time in the school, and we spend time in a childcare service or whatever setting it is that you're hoping to get, that you're hoping your intervention will be taken up, and have a look to see whether you legitimately think that it would be a reasonable expectation for staff to implement the program that you're wanting them to implement in their context with their resources. And working with them if you don't think it's reasonable to work out, how that could possibly be achieved. And I think that intimate knowledge of context can't be overstated. And finally, I think as a discipline, accelerating the development of implementation science requires, a commitment to collaboration, sharing, and open science. Certainly, the trials that we run here operate on an open science model, and anyone is welcome to have access to our data sets to ask interesting secondary questions from the research that we've conducted, and we'd be more than happy to share our research resources and infrastructure. We need to develop common measures and protocols for how we operate and start to use common language. There's a number of taxonomies that describe implementation strategies, just as there is taxonomies for describing behavioural change techniques in the field of implementation science. If you're interested in that, Byron Powell has done a lot of work, and it would be well worth Googling some of his work. And that's it. So I might hand over now to Chris.
All right, thanks, Luke. If I can get my screen up here. All right, hopefully that's working now. I think Luke's given a great sort of overview of implementation science when we're looking at physical activity and nutrition. I'm going to take a slightly different tact, and I'm going to talk specifically about a project that I'm leading along with Dave Lubens from the University of Newcastle. Just a little bit of background. I thought Luke's slide, looking at the graph showing the number of different studies, or the proportion of different study designs that we see in public health research. I have to say, I started off my career as one of those evil researchers who did cross-sectional research with maybe a small cohort study thrown in now and then. About 7 or 8 years ago, I decided that I really wanted to start looking at interventions and sort of designing interventions and working on interventions. But as Luke alluded to, all of those up until recently were conducted in quite a controlled setting. And while we did try to engage with stakeholders, it was probably not with the sort of deeper understanding and context that Luke was mentioning, and I completely agree with him. That's incredibly important. About 2 years ago, we started to engage with the New South Wales Department of Education. We'd established some pretty good relationships with them, but we started talking with them a little bit more about how we might take the scores intervention that Luke was talking about, and we could develop a model for delivery that would really work at scale. Let's see here. So that was the scores trial that Luke was talking about, that Dave Lubens led. And one of the things that we recognized was that not all adaptations would be effective. And so we wanted to try and figure out what might actually work to bring this efficacious intervention up to scale. One of the things we considered when we were talking to the Department of Education was how online technologies might be used. And we learned a little bit about using online interventions in a study that we were working on at the time called the AMPS trial, and that we've got some outcome data that's just under review at the moment, so hopefully that'll be appearing soon. So we had some experience there, and the department seemed to be very keen on this. And some of the teachers expressed that they thought it might be quite effective as well, as it would allow them a fair bit more flexibility. You know, as Luke talked about, the original SCORES intervention was a day-and-a-half of training for teachers that was then brought down to a 90-minute seminar. And our idea was that, and in speaking with teachers, was that if we could somehow provide some online learning that was engaging, we might be able to sort of stretch out that amount of time that they were learning and giving them more time to implement. So the stakeholders we were working with, I mean, the key ones were from the education sector. So not only the policymakers, but also teachers and principals. And we had a series of discussions. So, we had a working party really that came together every couple of months to talk about this. And we also had people who were from ACHPR, which is a sort of a peak body for physical education, and this was the New South Wales branch. And we also had representatives from the Office of Sport and Recreation. So all of these people were partners on a grant that went into the National Health and Medical Research Council, that scheme that Luke was talking about, which is the Partnership Project scheme. And so really what we were trying to do is get an intimate understanding of the context. So the model that we came up with was a sort of a blended or a hybrid approach, which included some face-to-face interaction, but also some online delivery that allowed the teachers to have a little bit more flexibility. And key to all of this is we really sought the department's input in terms of what would be manageable in terms of costs at a per school level. So we were trying to develop something that we could bring to scale. So just very briefly, the idea behind the face-to-face interaction was that we wanted to have some rapport building by the people who were delivering the intervention to the teachers, but also some accountability, so that when someone was coming back in, they would help to sort of keep teachers on track with some of that online delivery that was happening while they were away. Because we know from a number of other studies that oftentimes this online professional learning has very, very poor sort of adoption, and people sign up for a course but then don't actually follow it through. So we were looking to find ways to have a hybrid model that increased that accountability. So this is just a quick look at the website that teachers use to complete their online learning. And we're developing a guest site, so if people are interested in the next little while, we can provide you a link for that to have a bit of a look around. So this video that I'm going to play here is one that we play when we're recruiting schools into the project. So it's about 5 or 6 minutes, and it'll take you through the basics of sort of what we're doing from a teacher and a principal perspective. Hopefully you can hear the sound. Hold on 2 seconds.
Welcome to iPlay. Thank you for taking the time to watch this video about our professional learning research project called iPlay, which is supported by these educational bodies. Physical inactivity is a global pandemic. Despite Australia's reputation as a sporting nation, our children are among the least active in the world. The health benefits of physical activity for children are extensive. They include lowering the risk of type 2 diabetes and obesity, as well as improving bone strength and physical fitness. Physical activity also improves psychological well-being and prevents mental health disorders such as depression and anxiety. So what roles do schools play?
Schools are ideal venues to promote physical activity in children. However, recent reports suggest that many schools are not providing children with sufficient physical activity. Students are not developing the fundamental movement skills to allow them to be active outside of school and later in life.
You might know this already, and I know what you're thinking.
I really didn't think I would have time for this. I had enough to cover with literacy and numeracy topics, and I just thought there's only so many hours in the day.
What if I told you that physical activity actually helps children learn?
There is now convincing evidence that children who are physically active also perform better at school. A recent review of 38 studies involving over 70,000 students found that getting children more physically active helps them to spend more time on task during lessons. For example, one of these studies showed that primary students who participated in a simple physical activity program spent more time on task than students who did not receive this program. Physical activity has immediate benefits for brain function and long-term benefits for brain structure. When a child is physically active for 20 minutes, there is greater brain activation. In fact, research has shown that physical activity has the greatest effects for cognitive tasks that are the most challenging. And over the long term, physical activity increases brain growth.
Given that physical activity leads to more time on task, greater brain activity, and improved brain growth, you won't be surprised to know that physical activity makes a difference to academic achievement.
Recent reviews of dozens of studies have shown that there is a positive association between participation in physical activity and academic performance. This includes performance on standardised numeracy and literacy tests.
Benefits of physical activity for learning are clear. So why don't schools include enough physical activity in their school day?
I just thought this would be too hard. I'm not a specialist PE teacher. I've never been sporty. I never even taught sport particularly well, and I just didn't think I could.
Research has shown that lack of confidence is the #1 reason why primary school teachers don't feel comfortable teaching PE. This is not surprising when you consider that pre-service teachers are provided with very little training and support to teach this subject.
iPlay was really practical, and it was really well thought out in terms of how I could integrate it into my teaching. I was surprised how easy it was, and the kids really enjoy it, so it's a lot of fun.
iPlay is based on top quality international evidence and best practice. It has been tested in New South Wales schools with outstanding results.
When teachers completed iPlay training, students in their class were more active, with a 21% difference in activity time when compared to those who didn't take part in the iPlay program. It was also clear that students had bigger improvements in cardiorespiratory fitness when teachers completed iPlay training, with a 26% difference compared to the control group. Finally, students showed substantial improvements in fundamental movement skills, which are key for long-term activity and fitness.
The iPlay program was implemented by primary, non-specialist teachers just like you. Over the next 5 years, iPlay will be delivered in up to 200 New South Wales primary schools. We hope that this program will shape physical activity in Australian schools for the next generation of children and drive up Australia's ranking in childhood activity. By participating, you can be part of this vital change in improving our children's health and learning outcomes.
Sorry.
The iPlay program uses a whole-of-school approach, including curricular and non-curricular components. iPlay will provide you with professional training and support over 3 school terms to deliver the curricular components. And in each school, 3 leaders will be responsible for the non-curricular components. For the curricular components, the teachers in your school will attend a workshop and complete a series of online modules. To get the most out of the curricular components, each teacher will also get a mentoring session from your iPlay mentor, a peer observation with a colleague from your school, and a small group meeting with other teachers in their stage. By completing this training, you will receive 14 free QTC-approved BOSS Test TPL hours at proficient level. In addition, your school will receive a physical activity tracking system, which includes a set of wireless physical activity monitors. These monitors provide you with real-time objective measures of your students' physical activity during sport and PE classes. You also have access to hundreds of teaching resources on the iPlay website. In your school, 3 leaders will share responsibility for the non-curricular components of the iPlay program and facilitate training for the curricular component with teachers. While all teachers receive the 14 registered BOSS Test hours at the proficient level, iPlay leaders will receive additional hours at the highly accomplished level.
All right, we'll stop it there. Probably don't need to talk to you too much about the delivery structure. Or sorry, don't need to talk too much about the research structure. Sorry, I'm just trying to get my speaker notes up here again. Oh, they're gone. So essentially the delivery structure then, as sort of outlined in the video, is that mentors are trained by us and they deliver into schools. So they train up the leaders to do the non-curricular components and also the teachers who are delivering the curricular components. And this was a structure that we worked on with the Department of Education. So a key question then is who should the mentors be? And what we decided on, and using some principles that Phil Morgan wrote about in an exercise in Sports Science review last year, So we were looking for people who would be credible, likable, and relatable as these mentors. So what we settled on were these specialist mentors, or specialist PE teachers. And because as experienced teachers, they would be credible in the eyes of the teachers who were taking part. Unfortunately, our first attempt really was a bit of a failure. We found that the mentors who we trained up to go out and deliver the program in schools, they were expert teachers, but they really weren't experts in terms of the content that they were delivering. I mean, we certainly provided them with a lot of training, a couple of days of training about physical activity and promotion in schools and so on, but they really didn't have that sort of expert knowledge, and they really were struggling to deliver that content. So we went back to the drawing board, and we were really looking around for a way that we could allow these mentors who were experienced teachers to really do what they were trained to do and what they were experienced in doing, which was helping teachers to get better at what they do, but not necessarily sort of being quasi-experts in physical activity promotion. Now, what we settled on were we would develop expert content using videos. And the videos we would produce the videos that had the content, and the mentors would present these videos during the face-to-face workshop that you heard about in the film that I played just now. And also would be content videos on the website that teachers would use there. So the idea was that we could present, so you saw some of the things that Dave was talking about there in the video. So we would have experts presenting the content, and then the mentors would be there in more of a supportive colleague role rather than a quasi-expert. So a lot of our work then on these videos has been based on the success principles, which you might have heard about Chip and Dan Heath. So the idea with these principles is that in order for messages to stick, you want them to be simple and you want them to be unexpected. So unexpected messages require more of a level of deeper cognitive engagement. So people are if you like, their attention is piqued when they hear something that's a little bit unexpected. So when we're developing these videos, we try to get something that's a little bit slightly out of the ordinary, or maybe challenges the view just near the beginning of the video, so that we sort of grab their attention. We try to make things as concrete as possible, and that's fairly difficult sometimes for academics. We like to think conceptually, but teachers really don't care about our underlying theories. That they really care about is how can this actually make a difference in my classroom? So we do that in a number of different ways, and one of them is through sort of practical strategies, and sometimes we have testimonials and so on. We try to make things credible, as we talked about. So we have experts who are delivering the content, but we also make it believable by having these testimonials as well. We try to bring emotion as much as we can into these videos, so talking about how the teachers felt, and sometimes how the students felt as well. And we try to sort of, if we can, weave a story through each of these videos to try to make them a little bit more interesting and a bit more sticky, as Chip and Dan would say. So our video structure, and I do need to give credit to Mike Nattell, who's a PhD student of ours and an aspiring videographer. Our video structure tends to follow this layout here. So we typically present the problem, so what the issue is, and then some sort of a misconception. So that's the unexpected aspect. And then the refutation, so where we counter that misconception, so we say why that's not quite right or why something could be better, and then talk about the principle underlying what we're doing, and then try and get very concrete with a very specific solution. So that's sort of a fair bit to take in, but when I'm going to show you a video in a second, so you might, as you're watching it, try to see where the problem, misconception, the refutation, the principle, and the specific solution come in. All right, let's see if we can get this one going. So this is a video that is shown during the workshop that teachers have at the beginning of the intervention.
There are times in every school day, like before lunch or the final bell,
where students start to fade and get distracted.
When this happened to me, I used to try turning up the discipline or giving them the easy work to do, but nothing really worked.
We've talked about using physical activity to keep students engaged, and there are 3 common ways teachers try to do this. Sometimes teachers create more active playgrounds at recess and lunch. Sometimes they try to make the lesson itself more active. For example, learning about measurement and maths by testing how far they can jump off 1 or 2 feet. And at other times, they do really brief 2 to 5 minute spurts of activity in class called classroom energizers.
Classroom energizers have made such a difference in my classroom. After a classroom energizer, my students are always much more focused and happy to get stuck into the work.
A recent review of studies involving over 70,000 students compared the effectiveness of these 3 strategies for improving student engagement. While physical activity during breaks and in the lessons themselves did increase students' time on task, classroom energizers had almost double the effect of the other 2. Getting students very active for a few minutes as you transition from one activity to the next is a really effective method to increase student engagement.
It's so easy for me to use classroom energizers. I just go to the iPlay website and put them up on my smartboard. My students all have their favourite one and they'll often ask me if they can do it. In our school, some of the teachers were a bit worried at the start that they'd be the centre of attention during energizers. You don't have to get involved if you don't want to. With most of the energizers, you can just bring up the instructions and let the children do them on their own.
So when students start to get distracted, or when you're looking to transition between activities, why not consider classroom energizers? You'll find all kinds of great ones in the resources section.
All right, so after developing these sort of expert content videos, we went out again for another attempt in one of our pilot schools for the delivering the workshops to begin and having the mentors there more as a support and a facilitator rather than an expert, a quasi-expert. And I'm happy to say we certainly had liftoff on this attempt. In that second school, we actually had a problem with teachers then going onto the website and completing all the modules very quickly. There was 4 or 5 teachers that went online, and within about 10 days, they actually finished the entire course, which included 8 half-hour modules. And that obviously wasn't ideal in terms of them learning and implementing as they went along. So we had to sort of put in some sort of warning or suggestion messages surrounding that. That, of course, is a pretty nice problem to have. So it certainly seemed, at least in this sort of small sort of feasibility setting, that this new mode of delivery seemed to be working a lot better. And also the evaluations of the mentors went up. They were pretty bad in the original pilot study, but with the same mentor delivering in the second school, the evaluations by the teachers and the principal were significantly better. So a quick summary then. Not all adaptations are successful. I mean, I think Luke's exactly right. I think if we can be starting from the very beginning, developing interventions that are designed to be scalable from the very beginning, that's great and that's ideal. But in instances where we're trying to adapt an efficacious intervention that's worked in a controlled setting, we do need to really consider and have trial and error when it comes to looking at ways to adapt. We're certainly not going to get it right the first time or maybe even the second time. I think understanding that really in-depth the local context and working with stakeholders to develop a scalable delivery model is really important. And just be really ready to reinvent based on evidence. And that might have to be, in some cases, if you're sort of in the early stages, that might need to be some anecdotal evidence. But I think some of the best ideas that we got were just completely anecdotal suggestions by teachers just who happened to see us outside of a workshop, or a principal who wrote us an email about something, and we've tried to implement those and use some of those ideas to try and make the messages a bit more sticky and engage the teachers more with all aspects of the intervention. So I'll leave it there and turn it over to Harriet.
Great. Well, thank you both, Luke and Chris. They were brilliant presentations, and yeah, there's a lot of things to be thinking about for people who are wanting to design interventions and actually make them scalable. We do have 2 questions. I think the first one's aimed at you, Luke, as it was during your presentation. So Chris, if you want to comment as well, but were there any adverse effects of BMI measurement on children? So what were the numbers needed to treat and numbers needed to harm in the study? Because these are important measurement evidence-based practice.
Sorry, Harriet, can you just say that again? I didn't quite get it.
Okay. Were there any adverse effects of BMI measurement on children? What were the numbers needed to treat and numbers needed to harm in your study, as these are important measurements for evidence-based practice?
Sure. So, yeah, no, that's a good question. So I think from the trials that we've included in our reviews, we don't know. You know, that's adverse effects, like its impact on weight stigma, weight-based teasing, is rarely reported. So it's not something that we've picked up in our evidence syntheses. Although I'm sure there's been research done to assess it more broadly. In terms of our interventions, we haven't examined. We haven't actually examined numbers needed to treat for benefit. But I agree that metrics like numbers needed to treat are far more interpretable to policymakers or practitioners than odds ratios or relative risk. So I think the substance of the question I absolutely agree with in terms of presenting information in a way that is useful for end users who are needing to interpret it.
Great, thank you. Second question, I think both of you can comment on this. You both touched upon the changes made in your projects to scale up often impact effects, and Luke, you mentioned about the adaptations in SCORE, and Chris, you alluded to this also. And the question is, this is from Soren, who knows there are some studies trying to connect implementation quality with effectiveness. Have you been looking into implementation quality? If so, how do you measure this? Is that a clear question?
Yep.
Sure, yep. So do you want to go, Chris? Or?
No, go ahead, Luke.
Sure. So yes, I mean, we generally measure implementation quality in terms of fidelity of implementation. So was the implementation, achieved as it was intended? So were all intervention components delivered, and was there sufficient penetration of the intervention? So it's, I guess, a very rigid, linear assessment of intervention implementation and its quality. I think the challenge is so in our past research, we haven't really acknowledged the benefits or the potential benefits of adaptation. And I think the challenge for the research field now is how do you, not necessarily how do you measure implementation, because there is a number of measures for us to do that now. It's really how do you measure adaptation, because adaptation is assumed to be detrimental, but there's a beautiful review by Dulac and Dupree that talk about adaptation is almost synonymous with implementation. Things almost always need to be adapted, and this can have a detrimental effect, but it can also have a beneficial effect. And I think a number of the adaptations that Chris had made, at least at face value, look like they could enhance impact, not detract from it. So I think it's it's understanding what adaptations are made by who. So there can be user-centered adaptation. So that's adaptation that occurs by a teacher, for example, once they're exposed to intervention, and we need methods to measure that. But there can also be adaptation that occurs before it's delivered to the setting. So adaptation by a policymaker or a practitioner to reduce components or add components or change modalities. And I think the challenge is not necessarily how do we measure intervention, implementation, and fidelity. It's really how do we capture adaptation and its impact on, its effects on impact.
Yeah, I'd echo that. I think it is important to measure sort of the implementation. So, but maybe not so much in terms of the sort of traditional way of looking at fidelity, in that people need to rigidly adhere. So in ours, in our project, each time a teacher completes a module, they're asked to set an action plan. And then at the beginning of the next module, they're asked to reflect on their implementation of that action plan. And we do have some space in there for them to talk about ways in which they've adapted things and so on. So that's one way we're trying to capture the adaptation. The other thing I'd say is that, you know, we're taking a very sort of pragmatic approach with this. I mean, we're really treating it as though it is a real world study. So our intervention is evolving, and the intervention itself that some of the schools in the beginning is not going to be absolutely identical to the one that the schools get near the end of the study. And that's coming through learning that we're having. It's coming through funding that we've been able to get from the department and so on to improve some of the things that we're doing. So, I mean, some simple examples are, I mean, we're always developing new resources. So when we started the website last year, I think we had somewhere in the vicinity of 150 resources, and that number is growing sort of week on week. You know, we're talking at the moment about having a central support person who teachers and leaders and so on in schools can contact for ideas and suggestions, and that person will also be developing resources. So that's something that we may roll out in the next sort of 6 months or so. So I think it's adaptation by the end users themselves, but also adaptations by the people who are running the intervention as well.
Great, thank you both. That sort of leads quite nicely into the next question from Glenn Austin. Both of you have spoken about working more collaboratively with the intervention system to improve scalability. However, what are your opinions on working with the intervention target audience as well?
Yeah, I think that's really important. So our stakeholder groups that we had in for a number of meetings looking sort of at our working party had teachers and principals in it. We've been really fortunate, actually. About 50 meters outside the gate of our university, there's a primary school, and it's Marie Bashir Public School, and the principal there has been outstanding in terms of you know, making herself available and a number of her teachers. So we're constantly sort of going in and asking them. I mean, you know, many of the people on our team have experience as teachers, but having that sort of, you know, in the field ideas and just having people to bounce things off of has been fantastic. So it's not just a collaboration with the policymakers and it's also with the people who are in the field. Really important.
Yeah, I'd agree. And I guess I'd add to that also the people who are affected by the intervention, so students, and if it's in schools, parents, if it's, you know, parents and other stakeholders if it's in childcare centres, and not for the least in that often the individuals within the setting, so a teacher or a school or a childcare centre worker, is actually influenced by the views and the perception of children and of parents, and so having their input, I think, is you know, essential on multiple levels.
Okay, great. I've just got one question I think will probably bring us to the end of the webinar. So thinking of what's next, so you've done your trial at scale and maybe 3 to 5 years worth of funding. What happens beyond that? How are you planning for the handover to another organisation, or do you intend that these projects and trials become run by governments, etc.? What does that look like in your research?
Do you want to start, Luke?
Sure. So I mean, I guess I have a view that the end goal here is not that we hand over things and we wash our hands and we move on to the next thing. I think what we should be striving for, and this is not a short-term goal, this is a long-term goal, is that we really want policymakers, or, you know, government departments, any service that's responsible for delivering health promotion programs to the community or any hospital, we want those organisations to be learning organisations, and that they can develop, implement, modify, adapt continuously. so that there's not leaps and bounds in terms of they adopt an evidence-based program and then it's the same program for 20 years until the next thing comes along. It's a constant process of incrementalism, and so that requires constant adaptation, constant evaluation, constant improvement. And so I think we should be really supporting organisations to, ultimately to do that themselves, but it will probably involve ongoing partnerships with academics, and that this is an ongoing model of co-production between people with expertise in science, which is us, and people with expertise in how these programs are delivered in their context for their purposes. So I'm not seeing as there being any single endpoint.
Yeah, I'd agree. You know, we're having about monthly meetings at the moment with the Department of Education. Sorry. We're having monthly meetings with the Department of Education and now with New South Wales Health as well about the possibility of making this sort of a statewide program. And that's, you know, we're talking about different models there, which Luke alluded to. I mean, you know, one model would be one in which the researchers stay involved in the delivery of the program throughout its life course. And, you know, the intensity of that involvement is sort of yet to be determined. But I agree with Luke. I think that, you know, if there can be some learning in the organization, that would be ideal, but probably, at least in the medium term anyway, it's probably likely that those really strong partnerships in which researchers continue to be involved, at least in an advisory level, are probably the most feasible at this stage.
Great. Well, thank you both. I'll just check there's no more. Yeah, no, I think we're all done. So that was really great. Thank you both for responding to that, and thanks for your presentations. If anybody does have any more questions that haven't been addressed on the webinar, I'm sure you can contact Chris and Luke directly, and I'm sure they'll be happy to answer them. But thank you both for your talk. So really, really good and really informative. So I think that we'll call that the end.
Great, and thank you, Harriet, for organising it.
All right.
Yeah, thanks very much.
Thanks.
Bye.
Bye, everyone.
Bye.
Bye.